Sure. So thank you so much, ma'am, for having me as a part of this IC. Good to see the hall filling up. I think Dr. Siddharth was brave to go first. He almost was like a radio jockey with just the camera in front of him. But yeah, we've looked at drugs, we've looked at certain other aspects, and it's important to also consider varied options that are available and not there's not just one size that fits all. At this point, I would like to acknowledge my colleagues at the hospital and our School of Optometry who've been working on some of the work that I would be presenting here today. So, like ma'am mentioned, we have two guidelines to go by today. One, of course, is our own AIOS consensus guideline on prevention and management of childhood myopia. And recently, the WSPOS has also come up with a consensus statement. And these two kind of give us some method to the madness in understanding what options are available. They're not exhaustive, they're not comprehensive, and they're not very conclusive either. So you can't just go blindly by them, but they're a good start point for most of us. So we heard about atropine, but then is atropine really a magic bullet? It is extremely time consuming to tell a parent that your child has to use a medicine. We honestly don't know what will happen after 50, 60 years. We've been using it for about 10, 12 years. It's very, very safe. And how sure are we that patients actually are compliant to treatment? So here you're dependent on a child actually reminding the parent to put a drop into their eye before they go to sleep, or sometimes even use a higher dose of atropine where they may have their near work affected. And although ma'am did mention that 0.01% is commercially available, it is not available everywhere. So quite often you will prescribe a medicine and after 2 months they'll say the medicine ran out and sorry, I stopped using it after that. So these do come as challenges, and that's where environment as well as certain lifestyle changes come into play. Now, when we talk of environment as doctors, we're very good at advising people what to do, but often we forget to look inward. So the first step is to look at the environment of our own clinic. So when you look at it, we did a little thing, looked at varied refraction lanes across some of our hospitals across the country. So we had actually compressed our optometry lanes from 10 feet to 8 feet for lack of space. We thought it would be more optimal. And what we've also realized is 8 feet are what most common clinics are. But if you look at what is the accommodation you're inducing with a 8 feet room, you're inducing almost about 0.41 diopters. Now we thought probably it's just theoretical, it doesn't make a difference. So we did a little quick kind of a dipstick using an open field AR at three distances, and you suddenly realize that yes, even with the open field area, you're able to record it. So what the table on top shows is the mathematical calculation. So if you're using a shorter room, first of all, are you overcorrecting the child and therefore artificially creating a myopia progression? So can you slow down progression by just compensating for the distance is the first starting point. So I think that's something that every one of us can start doing from even tomorrow. The second thing we looked at was the eye level. So most of our pediatric optometry lanes have the vision chart at a much lower level. So does that really make a difference? We didn't find too much of a difference with it. So it's almost like it marginally reduces when you're looking at something that is at about 45 degrees to the eye, and it's very rare to get a child because invariably they're sitting on their parents lap, so that kind of an angulation does not really happen. When we talk of environment or lifestyle, again, you're looking at near work, age, schooling, time spent outdoors, and lifestyle factors. So all of these have been kind of blamed. In terms of education level, it's again thought that accommodation plays a larger role, and this can result in multiple things that kind of triggers a stimulus and makes the eye to grow longer. Again, there are studies to show that the exposure to the life at school rather than the age at which the child enters school or the age is more critical, and interventions therefore need to be at a school going age much younger rather than wait for the problem to surface. Then of course today we are in the era of NEET, JEE and multiple other competitive exams. Studies from across the world, there is not too much of data from India. We fortunately don't have too many cram schools, but yes, there are a few networks. It would be interesting to look at that, where children who are in predominantly academic oriented schools spending long hours, children who spend a lot of time doing near work with prolonged, when near work includes computer usage, smartphone usage, and reading, all of these children kind of showed almost like a dioptric increase equivalent to the number of hours. Now, in today's world, it is impossible for you to tell a child not to use a handheld device or not to do near work. So, we again looked at it saying that does brightness of the screen make a difference? Brightness definitely makes the person kind of push the screen away. One of the theory that our optometrists have is that when somebody is holding an object close, there's a pull-in effect that kind of makes the eye converge more, and therefore there also is some amount of accommodation. And this has been a theory propounded. So a lot of the work that happens actually looks at relaxing accommodation. So by just increasing the brightness of the screen, increasing the font size, there can be a lifestyle modification where you kind of arrive at a compromise saying that, okay, if you have to do near work, at least do this. Light has been proven again from across the world, higher light intensities. We don't know how it works uh, because we don't know whether it's a difference in topography, whether it's just the green nature that is there. Again, that is supposed to play a role in the sympathetic parasympathetic balance. Uh, could that trigger a dopamine release? We really honestly don't know. But today, schools in Singapore are mandated to spend a significant amount of time outdoors. Unfortunately, with COVID being blamed even today, a lot of schools have cancelled their PT periods or their play periods and have tried to compensate it with classrooms. So those of you who have an influence, please do encourage schools in your area to encourage outdoor time. Uh, Outdoor time again, like I mentioned, in a large cohort, they found that about 40 minutes of play showed a lower development of myopia. Uh, Brightness again seems to play a role play. Most of our classrooms are very dimly lit. Again, we don't have any data from India currently on it in terms of the ambient light in the room that can help it. Seasonal changes have been shown. Again, this is probably attributed to the sunlight exposure largely, and that could result in a thing. We played around with light to see that can we actually make any difference in terms of the accommodation. So we use colored light. So there was a theory that red light can actually relax accommodation. But what we surprisingly found is that even ambient green and red light actually relaxes accommodation, but we've not found it to be significant enough. It didn't cause too much of a problem to our students who were trying to read in that light. But yes, there is a challenge in terms of the contrast. Things don't look the same as a black and white thing. Uh, we again did a small study where we looked at children who spend more than 2 hours outdoors, and we found that even in those who had a family history, they showed a much slower progression with myopia. So today, as a routine practice, we encourage children to spend at least 1.5 hours every day outdoors in sunlight, and we kind of explain to the parent that outdoor doesn't mean you stand in the balcony, but you have to be either on a terrace or outdoors, where we think that it's the interplay of both the light as well as the peripheral stimulation into the retina that probably plays a role. COVID again reiterated this, where again studies have shown that there was a significant progression. There has been a study that looked at housing type, where they found that those people living in the lower floor or on a flat kind of a thing, they seem to progress a little bit faster. Again, probably with single houses, if you're staying on the top floor, the exposure to light is that much more. Obesity, physical activity again have been attributed. Again, is it a direct condition or not? Nobody knows. Uh, we also looked at vitamin D levels. Again, this is something that works. We found almost about 90% of our children are deficient in vitamin D, even those who are outdoor sports persons. Correcting vitamin D3 levels again seem to have some kind of a play in moderating the myopia progression. Now, coming to the optical part, should you undercorrect? So, again, this has been done to death. Undercorrection, we know for a fact, causes education delays, and it would lead to the child being bullied or ostracized. And there is very little evidence to show that undercorrection actually works. So it makes sense for us to give an appropriate cycloplegic correction. Again, how do you know the child is cycloplegic? Give them a reading chart, ask them to read a book. If they cannot read, only then take them up. Because typically our staff are taught to just put a torch into the eye. They look at dilation, not so much at the cycloplegic effect. Uh, do plus lenses work? Again, we did this little thing where we tried giving a bifocal and asking them. But what you will suddenly notice is that the way they're holding the chart, the child will never look through the near ad, but they will kind of bend their head and start peeking from the top of it. So with plus lenses, it's almost impossible to train a child to read. Only the children who are pseudophakic would probably do that. Multifocal glasses have been shown to work, but again, honestly, personally, I've not seen it work with any of the children that we've used earlier. Peripheral hyperopic defocus, we've been speaking about it. So the earliest intervention was looking at orthokeratology, which again has been shown to slow down control. But the recent studies with ortho-K again show it as a combination therapy along with probably low dose atropine, and that probably will work better. There are a few varieties of ortho-K lenses. Not all of them are equally effective. So it's good for you to understand what would work best and then look at that part of it. Uh, the DIMS lenses, again, there are three companies that have it. I don't have any financial interest in it. You have the Hoya, you have the SLR, and you have the Zeiss lenses. Each one of it works on a slightly different way. What differs largely is the clear zone that is there. Both the Hoya and the SLR lenses have about 9 mm that is clear in the center. The Zeiss lens has about 7 millimeters, so they claim that it is that much more efficacious. The DIMS lens has certain eyelets that kind of slow it down. Again, this has been proven to work in multiple geographies. It was made available in India more recently. We don't have too much of experience in terms of it, but yes, we do have some amount of children. The first concern we had was, would children be happy with it? Would they be uncomfortable? So when you look at it, you see some reflexes. When in clinic we found that the children were quite okay. And this is the child wearing it on the first day. Uh, she's doing her homework, she's doing her near activity, she's running around in the playgroup. So they adapt really, really, really fast. And this experience, I'm told, talking to some of the trade, is seen with all the three lenses equally. We again had some personal communication with the Hoya folks, trying to understand. We don't know the progression data from across India, but as a surrogate, they have this exchange offer where they say that all the companies today have it, that if the myopia progresses by more than 0.5, they would replace it free of cost. So we asked them, how many returns have you got? Fortunately, these lenses appear to work because in about a year's time, they've not had too many of it being taken back. The halt lenses of SLR again work on a hexagonal kind of a defocus zone. So we do have multiple options available today, and it is good for you to play around with it. In terms of lifestyle, encouraging children to spend time outdoors is a no-brainer. Getting the vitamin D levels tested every 6 months is probably two things that we could very immediately start off. Talking to schools to encourage outdoor play is important. Optical, what seems to work fastest are the DIMS lenses. Do you use it by itself? Do you use it in association with atropine? Because of the cost today, we are only able to encourage parents who are not responding very well with atropine to actually start using it, and that probably is what we would be doing. So thank you.